Hey, everybody. Laura, are you our new president? Did I hear that right? Awesome. Congratulations. That's fabulous. I was glad to hear it.
Yeah, we're going to be maybe, I don't know if you heard from Mark, but maybe adding some research stuff.
Yeah, I had some chats. I've been feeling out HealthGot to kind of get us back. So we've got some cool, we'll have some cool news to share with you soon, I hope. I don't want to steal his thunder.
Hi.
Hey, Sherry. Hey, Sharon. Hey,
hi.
Hello.
Sorry it didn't work out in Seattle last week, Josh.
I know. We were like ships in the night. We were so close to making that work.
It was very cool that it was, yeah, really.
Hey, everybody. Yeah. Hi, Emer.
Hello.
Hello, hello. Oh, man, you talk about glucose and lactulose and get all the naturopaths out of the woodwork. That's a good showing.
And also, Josh, I sent you an email about perhaps throwing in a discussion on fructose, and I started to actually put something together, but I think it's worthy of its own session. Yeah.
I was hoping you'd have something to share on that. I don't know I know Jason's argument, which I disagree with, but I'd love to hear your thoughts. And I don't know anything about the literature.
Well, I can present some data, but it does take me a while to pull it together.
Okay. Well, if you have anything to share at the end or in the middle, that'd be awesome too. We'll keep it loosey goosey. Cool. Maybe maybe we'll wait a few more minutes, but SSL still trying to connect and recording. Good. All right. Well, it's recording, so I'll just start. So you'll have to forgive me. What I did was I essentially combined a bunch of talks that I put together on this topic, and I think I got all the major studies. But if I miss anything, I think honestly, there's nothing. I think I got all the relevant stuff. Like there's a few new studies that basically say the same thing, and so we'll kind of walk through what it could mean. But like always, like just feel free to interject or interrupt or whatever. So let's talk about breath testing lactulose versus glucose. Okay, so to start with, everyone's kind of there's been a huge historical debate between whether you do lactulose or glucose, particularly with the Rome community. So the Rome community has been large advocates for using glucose. And then in 2020, the ACG guidelines came out that kind of reinforced the North American consensus. And basically, one of the things that they said is that you could basically use glucose or lactulose for these hydrogen breath test diagnoses, or for these hydrogen breath test testing. So all of a sudden it became like equivalent from a recommendation perspective. And we've done reviews on the ACG guidelines, and there's pros and cons of all that for sure. But that's kind of how it got on the main page. So you guys all know this, so just super briefly, but the basic idea is that so glucose is good. Well, lactose is going to be non-absorbed, right? So it's going to, in theory, make it to the large intestine. So the supposed benefit is that therefore you're catching the distal SIBO as well, because it lasts long enough to catch that distal SIBO. That's the main argument. The challenges are that lactulose is a laxative. And so it speeds up transit time. So the huge debate, and I've got a bunch of slides on that too, and if you're interested, we could jump into that. But there's some fascinating studies with scintigraphy and PEG and barium with lactulose that really gets into this debate. And then most recently, the Reimagine study really questions that. And so that's a whole nother interesting topic. Who's that? Question? No. Okay. A little chat. Let's see. Okay, Emer wants to get into it. Cool. Okay, yeah, we can get into all of it. So that's the main advantage of lactose, but the main concern is because it speeds things up, we don't know if we're measuring SIBO or just a rapid transit through the small bowel, right? And we're just hitting the the large intestine earlier, the cecum early. With glucose, it's absorbed proximally. So in theory, you're going to have less false positives, right? The glucose is going to be used up before it gets to the large intestine, but you may miss distal SIBO. So that's been the great debate there as well. And that's pretty much the quick Cliff Notes version of lactulose versus glucose. Also, lactulose is a prescription. Glucose is over the counter, of course, so that can make a difference too. But remember, even though we're used to thinking of glucose as this, wonderful thing that's proximally absorbed, not all the time. So especially people with IBS-D, especially people with diarrhea, think of their colon, think of their intestines as like this turbulent rapids down a river, right? So there's rapid transit in a diarrhea gut, essentially, right? So especially if you're testing for IBS-D or SIBO with diarrhea, even glucose may actually make it to the large intestine and give you a false positive just because of the turbulence and lack of absorption, et cetera. So this one study here, for example, of 25 patients with chronic diarrhea, they did scintigraphy here and a glucose hydrogen breath test, and they showed that 8 out of those 25 showed basically a peak where glucose was not fully absorbed. And another study also using scintigraphy showed that 48% of people with glucose at 90 minutes had a rise of glucose that had reached the cecum, right? So depending on the type of study, basically the take home here is not so much that the percentages matter, but that even glucose is not perfect, right? This darling of Rome has some of the same issues. Now, that being said, lactulose would have even more, more of those issues, in particular because it's also a laxative. But just remember that, you can malabsorb glucose, and that rapid transit is a major thing to consider whenever you're trying to read a hydrogen breath test. Okay, so what's everyone up in a tizzy about? So, the reason that I thought we would have this conversation tonight is because most of you were at the Gastro-AMP conference, and one of the speakers, whom I actually really like, made some comment about how glucose is preferred over lactulose and quoted some sensitivity and specificity numbers to back up that argument. And this is basically that argument in a nutshell. And this was pointed out all the way back in 2009. So the first iteration of Rome 1, back actually in Rome, basically kind of looked at the sensitivity and specificity of a glucose breath test or a lactulose hydrogen breath test, and tried to come up with what was the sensitivity and specificity of these breath tests compared to the gold standard. Now, remember, if you've been in any of my classes or anything like that, or you've gone through medical school recently, you've probably been forced to sit through classes on how to calculate sensitivity and specificity. But the way you do it is by comparing it to a gold standard, which you assume everything that the gold standard says is positive, is true, like honest to God positive, like God's eye view positive, right? And that's just because what you have to do, you have to compare it to something. So in all these cases, this is aspirate culture that we're comparing it to, and that's very, 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 very important. Now, the other thing is, they didn't talk about it in this paper. I'm obsessed with likelihood ratios. I think they're way more useful than sensitivity and specificity. You can calculate them. I'll give you the equation in the next slide. It's not important to memorize it or anything, but essentially you can calculate them using sensitivity and specificity and have a better sense of what is, I am recording, right? Yeah, I think so. What's useful or not. So when we run these numbers, you just have to trust me my numbers are right. The glucose positive likelihood ratio is 3.4. The lactulose breath test is 3.7. So higher numbers here are better for the positive likelihood ratio. And the negative likelihood ratio is 0.5 and 0.6. Actually, lower numbers are better for a negative likelihood ratio. And I'll give you an example of why that is in a second. But essentially, this is what we're talking about here. So even though if you kind of look at it like this, you see, oh, the sensitivity is up at 62% versus 52. That's what it translates to. Now, what the speaker was quoting was more recent meta-analysis. I think it was this one. I could be wrong, but there's a bunch of them that are basically come to the same conclusion, that when you meta-analyze all these different studies with glucose versus lactulose, you're going to see that one comes out over the other. So they argue in this meta-analysis that the glucose breath test is better because, look, the positive likelihood ratio is higher and the negative likelihood ratio is lower, which is kind of what you want, right? So that's the crux of the argument there, that it's a better predictor of truth when truth is defined by an aspirate culture. Okay, now this is, I do like this meta-analysis because they really tried to go into the heterogeneity. So I think I was talking to Emer about this. So a lot of another major issue with studies on breath testing and SIBO in general is that the definitions are all over the place. Like one study will use aspirate testing 10 to the 5, 1 per milliliter. One will use 10 to the 3. One will use a 120-minute cutoff for a breath test. Others will use 90. One will use 12 parts per million rise. Other will use 20. And so a lot of the debate is the difference that we're seeing real, or does it have to do with all this heterogeneity that each study is kind of measuring a different thing? And so one of the things I really liked about this particular study is they tried to answer some of those questions. Now, it's not important necessarily what each of these represent. I just wanted to show you that you can cut these up in different ways, whether you're using 10 to the 3 or 10 to the 5 or glucose or lactulose. But the main take home is, my kind of take home for all of us here is that they're not very impressive regardless, right? So here we have a pooled positive ratio of 1.3, positive likelihood ratio. Here a negative likelihood ratio of 0.79. Here we've got 2.4 and 0.6. So again, numbers not important to memorize, but these are the kind of numbers that we're talking about, like positive likelihood ratios of 1, 2, maybe 3. Negative likelihood ratios of like 0.7, 0.6, maybe 0.5. This is really what all this debate is about. Now, this is not to memorize. This is just for your record, so you can screenshot it if you want or something. But this is how you can calculate your own likelihood ratio, positive and negative likelihood ratio. Essentially, what we like about this is and I'm going to give you an example that will make sense, is it helps us understand what to do clinically. That's why it's a lot more useful, I think, than sensitivity and specificity. Now, as a rule of thumb, a positive likelihood ratio of 10 is considered excellent. And I'll show you why that is in a second. But that's the kind of numbers that we're really looking for. Maybe 5 could be helpful, right? But 10 would be ideal. Maybe 5. What are we dealing with? 1, 2, 3s, right? It doesn't matter if it's glucose or lactulose. That's what we're dealing with. With a negative likelihood ratio where you want a lower number, ideally you get a 0.1. Maybe you're happy with a 0.5. What are we dealing with? 0.7s, 0.6s, right? So again, we're not even close to the range for either test of where we would want to be to have real clinical utility. Okay, so why is this important? So let me just give you a super fast example. So the reason likelihood ratios matter is for your clinical diagnosis and decision making. So if you have a patient that comes to you with SIBO-like symptoms, right, with gut symptoms, if you look at studies that kind of estimate this, probably about 50% of them will meet either SIBO or IBS maybe not IBS, but SIBO diagnostic criteria or maybe Rome criteria, right? So people present with certain symptoms, maybe one half of them will actually end up having the disease. So that's your pre-test probability. Before you do any test, they just walk in your door with these symptoms. We're going to guesstimate that about half of them are going to have, we'll say, SIBO in this case, okay? Now, if you have a positive likelihood ratio of around 2, which is kind of what we were seeing, 2 or 3, what you do is you draw a line through the pretest probability, the 50%, through the likelihood ratio, which this case we'll say is a 3, which is generous based on what we saw, and out pops your post-test probability, which is 70%, which means that if someone walks into your door with SIBO-like symptoms, you test them with a hydrogen breath test, and assuming the best, let's say you use a glucose one, right? There's now 70% likely to have this condition that you're testing for. So you've gone from 50 to 70, maybe it's a little helpful. What would be really helpful is if you had like a 10 and now you're going from 50 to 95. And that's why 10 is so important, because no matter where you start, even with a low probability, you're ending up really, really high comparatively. And then conversely, if you test negative on a test, you use a negative likelihood ratio. That's the red line here. And a really good one would be a 0.1. So if you start at 50% and you drive through the 0.1, now you're only 10% likely. So that could be clinically useful. In our case, we're like 0.6 is a generous number. So that pops us out at 40%. So essentially they come into your office 50% likely, they test negative, now they're 40% likely. How clinically useful is that? Yeah, I'm not sure. It's certainly not a slam dunk. That's what I'm trying to, that's sort of my take home here, is that whether we're, if we're sort of quibbling about a 2 or a 3 or a 0.7 or a 0.6, which one's better? Okay, maybe it's better, but it's really not going to make much pragmatic difference as far as diagnostic decision making. So at the end of the day, the way I look at this is what we're really quibbling about is the difference between a C and a C minus on the utility of these tests, right? They aren't great tests. They both kind of suck. And remember, why do they suck? They suck when compared to aspirate testing as your gold standard. All these numbers are being derived from comparison to aspirate testing. Okay, so let's talk about that aspirate testing for a second. Now, the question is, okay, so let's assume that they don't do a great job predicting aspirate results. Now, the question is, do we care, right? Is aspirate testing useful at all, right? So here's a quote from one older systematic review that looked at the diagnostic criteria of SIBO and basically concluded the most provocative finding in this review was the lack of evidence to verify culture as the representative gold standard test for SIBO. In other words, everyone kind of agrees, quote unquote, that aspirate culture testing is the gold standard. Nobody really knows why. And there's little to no, I'm aware of literally none, evidence to support that this would make sense as a gold standard. It has historical reasons. So like when you look at like the beginning of SIBO diagnosis and how that was made and blind loop syndrome and these early surgeries where people had really, really high bacterial overgrowth levels, that's kind of where it comes from. So it's sort of like this historical standard that's just everything's just been compared to all this time. So there's lots of problems with aspirate testing. It's ideally you're doing anaerobic and aerobic culturing, but that's very rarely done. Early in my SIBO career, I used to do a bunch of these. I found a lab out on the East Coast. I found a GI group that would be willing to follow the Scandinavian criteria on this. And, they swore up and down that they'd be able to pull it off, and we'd overnight it. And the lab director would like wait outside for the FedEx and quickly get this stuff done. And it was just a total disaster and extremely difficult. And even if we could trust them, which I'm not sure we could, the major issues are sterile technique. So even really good, sort of like a lost art, how to sample from the jejunum or the third part of the duodenum appropriately and not contaminate your sample going in or coming out with the microbiome of the mouth. And that's one of the biggest challenges. And in fact, it wasn't until just a couple years ago that the Cedars-Sinai group invented a new device, which is basically like a sheathed sample collector. It's fully sheathed until it gets into the location. Then it's released, it opens up, grabs the sample, gets sheathed again, and then comes out to keep it from being contaminated. That was only invented relatively recently, and that was designed specifically for, my understanding is, the Reimagine study, where they wanted to actually look at the microbiome of these specific areas without being contaminated. So sterile technique is an issue. Basically, this is really not pragmatic. And even if it was pragmatic, or if you could do it right and find labs that would be willing to do that, the other issue is, where are we sampling from? Like, we're doing a single sample. So the standard technique is to basically go and get a 0.5 milliliter to 1 milliliter liquid from the third part of the duodenum or the upper part of the jejunum, and then basically culture that out anaerobically and aerobically. And the question is, well, that's just one sample from one place. What about distal SIBO? So in one way, what we might be comparing when we look at these breath tests is to say, how good are breath tests, whether glucose or lactulose, at predicting the aspirate results from proximal SIBO? And if you look at it that way, maybe it's not so surprising that glucose gets the C and lactulose gets the C minus, because glucose is going to be better at predicting the proximal SIBOs anyway, right? So that's just something else to consider. Okay, and now that was kind of where things were until a couple of years ago with the Reimagine study. Finally, with the Reimagine study, they were able to get, we think, sterile samples. They also invented a new methodology on how to get the DNA from the sample, because the stickiness apparently was an issue, different than collecting DNA from the microbiome in the large intestine. So they basically invented the methods for this, and how to sample and how to run the DNA samples, essentially. And in this Reimagine study, they looked at 140 participants, 20 of which also had a lactulose breath test. So these were patients that were referred for EGD to the hospital. They were enrolled in the study. They did not also have a colonoscopy, so they didn't have prep ahead of time, which of course would impact everything. And 20 of them on their own, they had enough SIBO-like symptoms that their doctor had previously or concurrently ordered a lactulose breath test. So these are lactulose breath test samples. And when you look at those samples, right? So now, why is this so important? Because they have lactulose breath test samples on these patients, right? And they can correlate it with the actual organism counts and the actual types of organisms, the species of the organisms in the small intestine. So that put to rest all the concern about, rapid transit, because we're not sampling from the large intestine, we're sampling from the small intestine, right? They're specifically sampling from there. And they present three arguments in support of the lactulose breath test and the 90-minute cutoff, which was, when you use the 90-minute cutoff, it was more sensitive and more specific than other time options when diagnosing SIBO. Now, here's the definition they used. They did aspirate testing in this one, but they used their special collection device, and they didn't use 10 to the 5, they used 10 to the 3. And they have a lot of arguments on why they think that's correct, which we don't have to get into now. But when they do that, they see that 90 minutes makes sense on a lactulose test. It's more sensitive and specific to predict the aspirate results. Also, it had a higher correlation with abundance of suspect bacteria. So one of the really cool things to come out of the Reimagine study is basically, what are the suspects, SIBO bugs in the small intestine, and what they're able to now correlate the large, an abundance of these bugs with lactulose breath testing. So again, more circumstantial evidence that this is a thing. And then also they did a really neat thing where they looked at energy metabolism, again, making gas, the metabolism needed to make the hydrogen gas, and also 90 minutes with the lactulose breath test had the highest correlation with the energy metabolism of hydrogen production. So all these sort of support this idea that a 90-minute lactulose breath test is a thing. Okay, so that's kind of the state of the evidence as I know it. And like I said, I might be missing a few studies, but I think mostly they argue the same thing. Maybe they quibble about whether it's a 2.5 or 2.7 likelihood ratio. But this is how I look at it. So basically, the way I look at it is, at the end of the day, it doesn't really matter much to me. What matters to me is how it will guide my treatment for my patient, and if it will inform prognosis or something I can tell my patient that matters to them. Whether or not I can say that this best correlates with an aspirate test, or I'm more confident in the SIBO diagnosis, I mean, that's important, but why is it important? Because the diagnosis in theory leads to a treatment that matters for the patient. So it would matter to me if the breath test results would inform my treatment and possibly inform the prognosis that I could tell the patient. So let's look at that for a little bit. So one argument you've probably heard from conventional docs is, well, just give them rifaximin, right? Like, why do we have to do a breath test? Just give them rifaximin. We could just empirically treat everyone. So that's an argument. It's not unreasonable, especially with the safety profile of rifaximin. It is expensive, but let's say it's covered by insurance for argument's sake. However, not everybody will respond. It is expensive. We define response differently. And also we may not know, which antibiotics to use. Do we use rifaximin? Do we use others, et cetera? There may be risks of overusing antibiotics, et cetera. So there's some arguments that maybe empiric is not ideal. And then the question is, well, then can we use breath test results to inform treatment decision? And we have some evidence to suggest that. So this is a subset of the Target 3 trial, which is a very large IBS trial. They looked at 93 patients with IBS-D. They used the new FDA endpoints, which is excellent, very conservative. about 50% of them improved with rifaximin. So that's great, right? Rifaximin has there's about a 50% placebo response rate, but rifaximin, about half of people got better with rifaximin if they were just given that. But a bunch of them were also given lactulose breath tests, and then they tried to see if that was predictive of response. And it was, whereas overall 48% improved with rifaximin, those that were positive on a lactulose breath test, ahead of time, 68% of those improved with rifaximin, right? So that's interesting, and that was statistically significant. They were 4 times more likely to have improvement, odds ratio of 4.3. Here's just sort of another image of that. So we have some evidence to suggest that whereas rifaximin makes sense empirically, those that respond to breath tests are more likely to respond, and so that might help inform your treatment decision. The other question about prognosis or recurrence, so they asked another question, which was, okay, what about people that tested positive? Does that predict recurrence or not? And it did not. So in their study, they basically found that whether you were positive or negative on your breath test at baseline, it didn't really predict the recurrence of your SIBO-like or IBS-like symptoms. However, there's some evidence to suggest it might be helpful in treatment choice. So I was really long-winded, and I'm sorry, I'm almost done. Last slide. Here's basically the way I look at it. Breath tests suck, but they're needed. I think personally they're clinically useful. No test is perfect. Breath tests are particularly imperfect. That's what I tell my patients. But I still find them very clinically useful. But they're not a slam dunk. Glucose and lactose both have their advantages, but like at the end of the day, we're dealing with pretty shitty options either way. And so the main thing that I tell myself in the back of my head every time is don't treat the parts per million only, treat the case holistically, right? There's so many possibilities for false positives, false negatives with breath tests of any substrate. You really have to look at the overall case and use breath testing as part of the picture. I am always highly suspicious of breath tests. I got burned really early. There was a great case that if you were at the Gastro A&P and you went to the session with Dr. Navidi on gut-directed hypnotherapy, he and I actually shared a really tough case with Dr. Drossman, who's the head of the Rome Foundation, and we think we're going to do like a 3-provider, 1-patient joint case study because there's a really, really interesting case. Dr. Navidi shared at the Gastro A&P his interesting findings with gut-directed hypnotherapy. I plan to share my interesting learnings in that case too, particularly in that this kid kept on testing positive on this test. We thought he had slow motility. We finally do a smart pill, and essentially he has extremely rapid transit secondary to this really weird IgG condition that I don't fully understand. And basically we were misreading breath testing for a really, really long time because even glucose was giving us large intestinal reads, essentially. So you just have to always be very suspicious of breath tests. And at the first sign that things don't make sense, always ask yourself, is this a red herring? Is this really driving the train here? Or is this either irrelevant or maybe a false positive or false negative? So that's all I got. And I'd love to hear what people's experience or their thoughts or maybe stuff about fructose as well, but that's what I got.
Thank you, Josh. That was great. That was a really good conclusion that you put there. I'm curious, for the Reimagine study, the 20 people who also had the lactulose breath test, did the study talk about any of them actually have diarrhea during their 3-hour breath test?
Oh, from the lactulose?
Yeah.
Oh, that's a good question. Not that I recall, but that's a very interesting, as like a proxy for rapid transit. That's an interesting idea. Yeah. Not that I recall, but interesting thought. Yeah.
I see. So this is another question actually for the whole group too. I'm curious if you have a patient, I have a patient actually, she was seen at the doctor. She had done, I think, maybe 3 lactulose breath tests at this point. Every single time she had a diarrhea within 30 minutes after drinking a substrate. So the doctor recommended another lactulose breath test. I'm like, how about we do glucose this time?
Yeah.
And she's always positive for her lactose test. Her glucose test is negative for all 3 gases.
Interesting.
So I'm just curious, like, what's people's experience? Like, have you actually run glucose for those people who actually have really, really responded to the lactulose? And I'm also curious to hear, like, people's experience as well.
Sherry, has she got a severe lactose intolerance?
Lactose
Because if they've got a
intolerance.
really severe lactose intolerance, they can have that response to lactulose, because lactose is the molecule on which lactulose is built.
Yeah.
So, yeah.
I think she has some
possibility.
level of intolerance, but I don't extreme. I think she's
It would need to be
actually
extreme, because it's only a tiny amount of residual lactose in
Right.
lactulose.
Yeah, hers is not extreme.
Yeah.
Mm.
I'd do fructose.
I'll be very curious too.
Yeah, tell us about that. I have so many issues.
No,
with
I'm going to leave it, Josh. It's too big. It's too big.
do it. Just jump in.
No, half an hour is not enough. And
Please, oh
we
my
can
gosh,
talk
you
about
have
stuff that's a bit
to.
broader. Yeah.
I want to join the fructose
Oh.
conversation. Let's do it.
Yeah, we
Yeah.
all want to hear the fructose.
Yeah, I'll talk about it next month. Look, put it in your calendars. But because I've got some questions around this whole what you've been presenting in the glucose lactulose thing. And while you early on, I mean, great presentation, Josh. I mean, it's really good to bring it all to the table for robust discussion. But we also have to remember that there are some caveats on the dosing and the internal metabolism of those test substrates. So, for example, not every bacteria produces or possesses a disaccharidase capable of cleaving lactulose. Yeah, so you may see a negative or even a flat line on a lactulose breath test and a positive on a fructose next month. So that's one little thing about that is lactulose is still not the best substrate, right? I also you didn't refer to it in your presentation, but I'm increasingly referring to the European guideline for breath testing. It's a bigger consortium of people, and probably a little bit, I don't know, I think it's a bit more open discussion. And they've got some interesting variances and some interesting congruences with the data that is commonplace out in our community. So, for example, they're also saying, yes, you can use glucose or lactulose. But one of the problems with the glucose testing is the dose. So the American guideline, I think, is still saying 75 grams. That's a pretty wacky dose. And the European guideline says 50 grams. And just between you, me, and all of those gateposts out there, in my study, we used 50 grams. We followed the European guideline. But the other thing that the European guideline is saying is that the positivity cutoff, they're not endorsing it, they just state that the most used cutoff value for test positivity is 10 to 12 parts per million, but they didn't reference that. So I find that a bit of a bother. And then the other thing that they bring up in that paper is that they reckon, and they cite in it, that 10 to 25 grams of lactulose is unlikely to hasten the oral cecal transit time. Now, I know all of those studies that have looked at that were small. That scintigraphy study was tiny. Even the Reimagine study, that was small. 20 people, that's not many. So anyway, that's my kind of few bits of tuppence.
My thought on that 75 grams of glucose, Sharon, is just that that's what they've always used for glucose tolerance testing. Glucola, 75 grams. So they figure, That's the dose.
Yeah. Except for in pregnancy, and they use 50 grams. And I haven't done the data yet, but we diagnosed in my study a couple of people with diabetes and multiple people with impaired glucose tolerance based on 50 grams. So even for diabetes is 75 grams. I mean, that's a supraphysiological dose of glucose. Yeah, you'd have to eat a lot of stuff in your diet to get that in one hit. So is it fair?
Well, actually, you know, I've been doing a test for decades through Diagnostics Lab that does what's called a carbohydrate challenge. And it uses food to measure insulin pre and post meal.
Yeah.
But it's food. It's not, and it's
Mm.
not an outrageous amount of food, really. You know, it's a certain number of pieces of bread and so many grapes and that sort of thing.
Yeah. Far more real world situation, right?
Yeah.
But, you know, we just happen in my clinic, we routinely monitor blood sugar just with a capillary every time we do a glucose test, just because we can. So why not? Yeah. Anyway, that's a deviation. Nice to see you.
Yeah, same here. You know, Sherry, I was going to say that I have brought that up with patients who say, oh, I don't want to do a breath test. I get such bad pain and diarrhea every time I do it. And so I say, well, you could do a glucose breath test. And they said, oh, but that's not as accurate. So I don't want to do that. You know, even though it's more sensitive and specific, the patient doesn't want to do it because they've read that the gold standard is a 10 standard, really. So I haven't used it much.
Mm.
With the dose of glucose, there was a study in 2016 where they showed that 75 gram dose of glucose, validating with scintigraphy, demonstrated a high rate of false positives. So obviously 75 grams is more likely to aggravate a diarrheal rapid transit episode. Yeah, so that was, yeah. And in 1992, there was a study that was similar, but they didn't do scintigraphy, I don't think. So, yeah, I think you need more than just one of the sugars.
Maybe we'll end up using a combination sugar.
Mm-hmm. When I first got into breath testing, I wondered why we weren't. Yeah. Take someone brave to do a large cohort study.
I think I know somebody. Yeah, and I think I think the biggest issue is just like what we're comparing it to. And so to me, it makes sense to be comparing it to treatment response. Like that makes way more sense to me than comparing it to some historical standard or playing with dosing. Because again, like you look at these dosing studies, and Sharon's right, like they use different dosing in these different studies. And some of the metas tried to do subgroup analysis on that. Now, metas are generally underpowered, but subgroups are generally underpowered in metas, but it doesn't really matter because the point estimate is still super low. So even though it's imprecise, like, okay, but the point estimate is very low. Basically saying like, yeah, you can cut it and dice it any way you want, but we're still not talking about likelihood ratios that are going to make a difference. And again, no one's talking about treatment response. Like there's no thing that says, okay, therefore you're more likely to do X, Y, Z. So I think that's the thing that gets me the most.
Josh, I have a question, and that is, with IBS having such a high placebo response, does any of this really matter? I mean, does it?
Probably not, I think. I mean, rifaximin has what, like a 9% absolute improvement over placebo in the large IBS studies.
Yeah.
And so it's like a numbers needed to treat of 11. So you have something that is placebo response is 50%, and not just like improvement, like FDA endpoints improvement. 50%. If we had a drug that was like or an herb that was 50% response rate, like damn, that's impressive, right? And then you get this $2,500 for 2-week drug that takes it from 50 to 59, you know? And so I don't know. Yeah. So I think the SIBO stuff works, but I think, you know, we're dealing with marginal cases, you know, another 10% here, 5% there. is my suspicion.
So that was something I wanted to comment on was why even bother testing as opposed to giving it like an honest empiric trial? Because if you have a test that's not good, a test that's not covered by insurance, medication that's also not covered, or if you're pursuing the medication route, a medication that's typically not covered by insurance, putting them through unnecessary stress if they're, if they find that the testing is really uncomfortable, why not, if you've done a thorough workup at this point already, not just say, hey, let's try treating, a possible SIBO with, this holistic approach, as opposed to having them go through all this testing and whatnot and kind of, in my opinion, wasting resources. Yeah,
it's a good question. I think, and I'm sure everyone on here will have a different answer. I'll give you mine. I think whenever you're making an empirical call, a lot depends upon your intervention choice, right? And so if our intervention choice was like neomycin and clindamycin or something like that, like, okay, like that's, I'm not going to give everybody neomycin just for shits and giggles, right? Rifaximin is very safe. So I'm not worried about the safety profile. So I've got no problem with that, but it's very expensive. It's $2,500 for 2 weeks. And usually you need multiple rounds of treatment for SIBO patients, depending on how serious it is. So the way I look at it, Adam, is when, if I have a patient and I suspect SIBO and they know it's covered by their insurance, that's usually my first option. I'm like, let's talk about philosophical choice here. If you prefer herbs, that's one thing. If you prefer drugs, like we've got some decent data that this is a good empiric option here. It's covered by your insurance and it's super safe. Let's give it a trial. Let's see how it does. If it's not covered by insurance, then that goes into the discussion because it's so expensive. And then if they want to use herbs, which have a higher, in my experience, side effect profile and are more expensive than an insurance covered option, then that also goes into it. So I don't think there's anything a priori wrong with empiric, but it kind of depends on the situations. And then the other thing is, I think a lot of this has changed with handhelds. So what I do now is I'll do a baseline test, I'll do an intervention trial, and then I'll do a really tight pre-post test. So if I see that they have a 60 parts per million rise, we give them rifaximin or we give them herbs, and now they go down from 60 to 40 and they're like, marginally better. That gives me a lot more confidence to do another round and not pivot or abandon, because I'm seeing gas level changes and some symptom improvement. So I think that kind of changes things a little bit too. And with the handhelds, it's like a lot cheaper to be able to do that. So I think that plays into the calculus, but I'll let other people kind of weigh in on that too.
But doesn't that kind of contradict what you said about not treating based on parts per million? Because, then you're going to run into that similar case that you had where, you kept ordering the SIBO testing on that patient. You weren't getting clinical improvement.
Yeah, very good. So, so yes and no. Again, I think it depends on the situation. So if you were just running test after test after test without having a single variable that you were testing, I would agree. If you were having gas changes that were incongruent with symptom change, I would agree. So one thing I talk to patients about is I want to try to prove a link, or I want to unlink or delink, I don't know what the word is, unlink your gas from your symptoms, right? If they are having no symptom response, but I've taken them from positive breath test to negative, that was a red herring. It's nothing to do with your symptoms. We're moving on. We're immediately pivoting. If their gas level improves partially and their symptoms improve partially, we talk about doing another round and tracking as well. And then if their symptoms improve dramatically, but their gas doesn't change at all and they're still positive, we've also unlinked it. And we stop using breath testing to guide us, right? We'll just use the symptoms. So I agree. And I think there are, anyway, in my mind anyway, that's how I look at it. I try to make sure they walk in step together, always being skeptical of the gas levels.
Yeah, I'm with you on that one in terms of not just the numbers, but the associated symptoms. And I think it's something that in our community, people forget, and they just treat the test result. They know that they've done the test because of gut symptoms, but they just treat the test result without actually looking at it with regards to what symptoms were aggravated and at what time, what happened to the person over the course of that breath test. That's one of the European guidelines as well, is looking at symptoms. And And in a lot of places, it's not even, I think in some labs, they don't even report the symptoms. You know, they just give you the numbers on a thing along the bottom of a page in a pretty graph without any symptoms being documented. But on the other hand, I have concerns that a positive rise on a breath test, no matter what the substrate, without symptoms, is still going to contribute to a dysbiosis. And maybe that breath test substrate and that breath test episode didn't aggravate the symptoms, but it probably sure as hell fed the bacteria that are going to cause them when next time they try to chow down on some onions or something. That's kind of one of my concerns running in the background with a positive breath test that isn't associated with symptoms. Will we see a dysbiosis? Wait until we've analysed our data.
I've always suspected that the difference between somebody with a positive breath test, if it's a true positive test, compared to somebody who doesn't have a positive breath test, one of them, let's put it this way, two people with a positive breath test, one of them has symptoms, the other one doesn't. Why did you do the test if they didn't have symptoms? I don't know why you would do it, but I think the difference is one of them has visceral hypersensitivity and the other one doesn't. So they can feel that distension as pain. They can feel the peristaltic variance as pain, and the other one doesn't. But why would you test somebody if they didn't have symptoms?
But the symptoms I'm referring to are symptoms that are aggravated during breath testing. So that's one of the criteria for a positive interpretation of a positive breath test, is that the gas production is associated with an aggravation of GI symptoms, rather than, you'd expect you're not going to send people for a breath test unless they've got a GI problem that you're wanting to identify.
So we keep track of at each marker if they're having symptoms, right?
Yeah.
So what would you do then if their first test, they have a lot of symptoms during the test after they drink whatever it is, lactulose, and then on the follow-up test, they feel fine. It was easy. It was no symptoms. Would you take that as saying a lot?
Yeah. If there's a shift like that, I would.
I was going to ask you, Josh, too, how soon after treatment do you have them do another handheld test?
If we're in treatment and testing as we go, if it's a treatment cycle, the tail end of a treatment cycle. So Allison, I do 6 weeks, so rifaximin 2 weeks. So they'll test the day before, they'll do rifaximin. At the end of the second week, they'll do a breath test. And we're looking for a trajectory of change.
So at the end of a second week after treatment?
Yeah, or the end of however long the treatment cycle is. I'm looking for a trajectory. So and it's not going to be perfect, but it's a guide for prognosis. So if I get a 20-point drop with one round of Allison, which for me is 6 weeks, and I still have another 40 points to go, then I'll tell them, look, ballpark, we're probably going to be talking about another 2 rounds if this trajectory, of 20 points per round keeps up, type of thing.
But do you have a period where they transition off of treatment and onto a prokinetic? Or I think SSL, is this what you were trying to ask? Do you test immediately, the day after taking Allison, or do you give any time between?
I don't. It depends on what I'm using it for. If I'm trying to make a formal diagnosis, I'll follow the standard 2-week guidance or whatever. But if I'm looking for a response to treatment, and I really want to capture that response to treatment and not a blip back up, waiting 2 weeks or so, then to me it makes sense to do a tight test like that if there's no added cost, which is the case with handhelds.
I'm still using spot methanes. So if I have somebody with a high baseline methane, after a month of herbs, I'll do a spot methane, just 2 or 3 samples without lactulose or any other substrate after a 12-hour overnight fast. And I'll see what's their baseline now. They did a 2-day prep diet and they had a baseline of 50. What's it now? Is it down to 30? Okay, let's do another month of this treatment.
Yeah.
And that test only costs the patient $35.
Yeah, I do that.
If you had a handheld, you could do that.
Yeah.
I've started immediately transitioning from treatments to prokinetics, and I tend to favor like Prokine or motility activator. And then I usually will retest like 1 to 2 weeks after being on that to kind of capture what level of clinical improvement and gas level improvement you can have when somebody's on like a maintenance style protocol.
You're doing that with even for hydrogen?
Mhm.
And,
Yeah.
and I guess I would be worried about like false positive on the hydrogen if you're speeding up transit. That
Yeah,
would be
I think
concern, but
I think about it, and you can like correct me about this, but I think about it as in like it's not your migrating motor complex being stimulated to move the like small intestines more quickly that is causing the diarrhea. It's the gas levels that are causing the diarrhea. So the prokinetic, if your diarrhea is caused by SIBO, is not actually going to worsen your diarrhea because the thing that it's treating is not going to be worsened when you're on the prokinetic. And I haven't seen clinically anybody have worsening of symptoms on a prokinetic. So it's kind of tracked for me.
I think also, you can certainly have worsening of symptoms on a prokinetic, especially with someone with high visceral sensitivity, or someone who has been blocked by significant residual stool in the colon, shows up on a CT or a flat plate abdomen or an MRI of the abdomen. They'll report significant residual stool in the colon. Those are people that if you give them a prokinetic, especially one that has serotonin receptor modulation, like motegrity, you can really aggravate them because you're trying to move an immovable object. But if you're using something like Prokine or motility activator that are more upper GI tract focused prokinetics, I haven't seen that.
Yeah, and I don't usually use prokinetics like empirically. This would be specifically after like testing and treatment for SIBO. So in a sort of unique clinical scenario, or not unique, but specific one.
Yeah, I always do that too, because it's part of the prevention protocol. If you just stop treatment and don't go into prevention protocol, if they already have a deficient migrating motor complex, which we kind of almost assume people that have this condition will have, then you're asking for a relapse.
Do we have any?
I want to give you a chance to defend yourself in absentia. Can you weigh in on your fructose findings? It sort of came up early on. Sharon was like, "Oh, what about fructose?" And she sounds like she has some data she's going to present. And I was curious if you wanted to weigh in on your experience.
Yeah, I can. Sorry, I'm late. I was teaching another class, and I was like, "Hold on, I'm back in time to catch the end of this one." I had a hard time resisting breath testing ones. Yeah, and I think for me, it essentially was just because I'm in Australia. I'm influenced by America and Europe. So Europe is glucose, America is lactulose. So everybody I suspected of SIBO, I was originally just doing those two tests on, not just one or the other, but both. And then I was also when people were reacting to fructose containing things, I always would toss in a fructose. And then what I started seeing was this pattern that wasn't what it was supposed to be seeing, which was, malabsorption to the colon, then a spike of gas in the colon on fructose, as I was seeing these big spikes on fructose at the 20-minute mark or 40-minute mark. And I'm like, that's not what my papers are talking about fructose intolerance here, which is supposed to be, malabsorbed reaches the colon fermented. And I was like, okay, well, why is it only glucose that tests for SIBO? Why do bugs only eat glucose, not fructose or lactose? So you see these people who spiked on lactose at 20 minutes. It essentially worked out that you treat them for SIBO and the fructose intolerance goes away and you don't no longer get any rise on fructose. So it was very clear. And then from that point, I started testing all my patients with the 3 sugars because I started seeing that lactulose would miss patients, glucose would miss patients. And when I did all 3, I'd get a much more accurate representation. And I think at one point I just sat down and I think I presented this at last year's gastro A&P of just getting 130 consecutive patients and just looking at the data that I suspected of SIBO. I sent for triple sugar testing and to kind of try to correlate results. And obviously I don't have my own capacity to go down there and scope and, you have a gold standard to compare to. But I did find that, from the way I kind of analyzed the data that lactose on its own missed, I'm trying to remember what the figure was, but it was nearly 20% of patients or something like that, versus and fructose on its own was like 87% or something like that. But when I combine the two, is 97% thereabouts of picking it up. So since then I've dropped off glucose because it wasn't actually adding to my diagnostic rigor in that it wasn't actually picking up things that they were. But I do think that because fructose is it's slow absorption. Unlike like glucose, is a very active absorption that I think does pick up SIBO in the upper small bowel quite effectively. But if it's middle small bowel, distal small bowel, I don't think glucose is particularly useful for that. Obviously, lactulose is, but only if the bacteria that are there can eat lactulose, which has always been my main concern with relying solely on lactulose, because a lot of bacteria don't. Whereas fructose is eaten by pretty much all microbes, and it's so slowly absorbed. And I think this is why you can pick up SIBO where other sugars cannot, because it can feed the ones that lactulose can't eat, but it's so poorly absorbed that it doesn't just go gobbled up in the proximal small bowel.
So I missed that last time. So essentially, you're limiting the false positive from fructose intolerance by saying, well, if there was a blip and then there's not after treatment, it's not fructose intolerance, and also assuming that if it's an early rise, yes, it could be rapid transit, but it's more likely that it's SIBO than rapid transit.
Yeah, and because I'm doing glucose, I'm doing lactulose, and I'm doing fructose all at the same time. And why would you'd expect presumably an early rise, and lactulose can cause an early rise. Geez, there's that paper from 1998 by Miller et al. Showing that giving people lactulose, their oral cecal transit time decreased to like 40 minutes or something. I can't remember what it was, but it was pretty dramatic. So we know that lactulose can cause be in the colon really quickly as well. But we seem to still think those initial blips are small bowel. So I don't understand why we can't do that with fructose or lactulose or glucose either. Glucose is obviously gets absorbed, but with fructose or lactulose, if there's a blip at 20 minutes, I don't know why we go, that's not SIBO. It doesn't make any sense to me. Whereas we say, okay, well, only this sugar is SIBO and the other ones are not. When clinically you treat those people and you get a different response. So I still recall having one patient that went to see a dietitian and got breath tested with fructose 5 years before coming to see me. And she still had, symptoms improved on a low FODMAP diet, sure, but still had ongoing symptoms. Get her to bring in her breath test. And yeah, she had fructose intolerance, but her spike was at the 20-minute mark, and I was like, okay, well, let's just treat this for SIBO. You treat her for SIBO, and then she can now eat apples and mangoes and pears and all these things she couldn't, cured her fructose intolerance because it was caused by SIBO. Yeah, there's other people that have that. The classic thing of flat line that reaches the colon. Treating SIBO doesn't help those people, because they don't have it. But they clearly benefit if they get picked up on breath testing at the early rises on the sugar test.
Do you ever see a double peak in fructose testing?
Yes.
Occasionally, yes.
Yeah, I see.
But less often than not, or?
Yes,
less often than not. Yeah.
The more fructose testing I do, the more suspicious I have become of a non-significant blip on a glucose challenge. So when I look back at people who've done just glucose and lactulose, and the lactulose just showed the normal colonic rise, but the glucose had a not diagnostic increase at 30 minutes, for example, well, most of the glucose has been absorbed by then. So there's not much left to ferment if now the remaining glucose has reached a part of the small intestine where there are bacteria. And like I say, the more fructose testing I do, the more I have become suspicious of those minor increases in glucose, particularly of hydrogen on a glucose challenge. You've taken the wind out of what I was going to present next month, Jason.
Well, you're presenting like research data. Mine was clinical
it's
data.
not research data, but I've got comparative data. So I've actually been through a bunch of cases and pulled, and put them side by side, so you can actually see the differences between the different breath tests, and then pulled out some other information that discusses how we should be using fructose. Do we really understand it properly?
Do you have treatment? Do you have treatment response data?
Me not. I'm talking because this is just an exploratory study.
Oh, from the lab, not from your clinic. Gotcha. Yeah.
Okay.
So Jason, you're doing testing using all three substrates together?
No, separate. So they would do
3 different
usually-
days?
Yeah, glucose first. If there's no flare up of symptoms, they do fructose the next day. No flare up of symptoms, lactulose last. And if there's a flare up of symptoms, we wait a couple days in between for things to settle before they do the next substrate. I wish it was easy to do all 3 in one, but I just think that the improved diagnostic accuracy, because I've just seen so many flatline lactulose that were picked up. I picked up SIBO with glucose or fructose that I just can't feel comfortable relying solely on lactulose as a diagnostic tool.
And the dose of fructose is what?
I think it's 50 grams,
25.
25 grams, 25
Yeah.
grams.
5 in North America. Yeah.
25.
Yeah, 25 here too.
Same as lactose.
So that's interesting. I hadn't thought about this, but I just presented some data on our hydrogen sulfide registry, Jason, and one of the findings was that, or the suggestions was that a flat line was the most predictive of treatment response. And the idea, we couldn't prove it, we didn't have enough data to run the statistical test, but the idea was, even if you're negative on hydrogen sulfide and negative on methane, which the presumption is that's what's driving the flat line, that there might still be a rationale for treatment. And I wonder if it's just that they weren't eating the lactulose.
Yep.
And if we would have done a fructose test,
Yep.
it would have been positive. And that's
Quite
why they
likely.
responded.
Uh-huh.
Yeah.
Duh. Yeah, that's a really good point.
You know,
Yeah.
park it next month.
Yeah.
Yeah, because for me, like I learned about lactulose as a prebiotic. That was my first interaction with lactulose. So I was using it as therapeutic as a prebiotic due to its selectivity fermentation. When Pimenol first came out with let's use it as a breath tester for SIBO, and I was like, I don't understand that because it's not going to feed a bunch of bacteria. Like that was clear. So I've always had some questioning around lactulose at that initial time point. And for me, it always made sense that you're going to miss certain overgrowths because they just can't eat lactulose.
So I have another question that maybe we can do another time, and that is, the Cedar-Sinai group says Klebsiella and E. coli are the big ones in overgrowth, right?
Mhm.
Do those bugs both eat lactulose or not?
Generally not. I mean, I think if you look at the data around it, not so much. Like I think it's also tricky too, because if you take microbes in isolation and give them no other food source, then sometimes they can evolve to the point where they can. But in general, you would not see E. coli or lactulose as consumers. And we certainly know from prebiotic studies and that those populations of those 2 bugs go down with use of lactulose.
Now, hold
Like
on.
that.
How does that make sense? Because in Reimagine, they also looked at hydrogen gas metabolism, and that went up concurrently with the lactulose hydrogen.
Yeah. And whether there's some sort of cross-feeding or there's other bugs that are present that can utilize that, I'm not sure. Yeah, I can just talk about the
they're
research data on
growing.
lactulose.
Interesting. So like
Yeah.
they would, so Klebsiella coli would overgrow. That was shown in Reimagine pretty clearly, like pretty dramatically. And it's associated with hydrogen production and metabolism for gas production. But maybe it's other bugs eating the lactulose and then feeding the overgrowth of E. coli or
Potentially so. I mean, I'm just trying to think back of some stuff that was studied before the Reimagine study done. And, they looked at like 5 different genera being overgrown or 4.5, I think it was, in people's guts. It wasn't just one different genera. It makes me think that there's potential for cross-feeding situations going on there.
Didn't we find that there were different niches? Oh, hi, by the way, I've been very nervous to speak, but didn't we find that there were different niches of bacteria too that fed the hydrogen producer and hydrogen sulfide producer microbiomes in the small intestine versus the hydrogen producing bacteria that then feeds into methane? So I wonder if maybe the different niches that are feeding hydrogen and hydrogen sulfide versus the hydrogen feeding methane feed on lactulose versus glucose and fructose. And then my other thought is, I wonder, I really love how you brought up, Jason, how you use the fructose data to then guide how the clinical response to treatment is. Because my thought on it is, what if fructose intolerance is something that's secondary, kind of like secondary lactose intolerance, and maybe it's not even necessarily SIBO, but it could even be something else that then causes inflammation that decreases, the ability or saturates these transporters more quickly and then causes a secondary intolerance. So
yeah, and you totally do see secondary stuff too in celiac patients, in radiotherapy patients in the gut. chemotherapy patients, you do see that. But that's the classic scenario where it flatlines and then spikes in the colon in that situation. And then you focus on healing the gut, and then you no longer have a reaction to fructose anymore.
Got it. So interesting.
Yeah, it is, because there's all this discussion about secondary lactose intolerance. And again, it always blew my mind that there's this obvious, I can see it clinically, of the secondary fructose intolerance from my patients that have just done radiotherapy or chemo or gets this massive gut damage. And there's my celiac patients too. And you heal the gut, and all of a sudden those foods are no longer issue, just like secondary lactose intolerance. It's just not widely discussed. Yeah.
And the idea of histamine intolerance too, as opposed to like everyone having MCAS, of there being a subset of people that aren't secreting the DAO enzyme that's a disaccharidase, and thus having like GI overburden, histamine intolerance. But I also wanted to throw something out there about the other discussion. So we were talking about reasons for a flatline breath test and the presumption that it's methane that causes the flatline. And then the other idea that it is the composition of the microbiome that causes the flatline. And I just wanted to throw out there, I feel like when people have talked about fast transit for breath tests, they talk about like seeing an early rise, but I have a solid subset of patients who I've ended up with just these flatline breath tests on the TrioSmart. So I know it's not hydrogen sulfide, that I then talk to after the test, because I'm like, something's fishy here. I usually test with lactulose because TrioSmart won't run fructose. Also, like, point for anybody in the United States, like, don't try to fructose test with TrioSmart, because one time we didn't have glucose in clinic and I had a patient that couldn't tolerate lactulose. And I was like, just get whatever, just go to the store. If you see fructose, glucose, measure this much, take it. And then TrioSmart got in touch and was like, we will not result the breath test. And I was like, surely this is a mistake. I only practice due to North American consensus guidelines. The patient, I think they are mistaken. And then they called the patient again, the patient insisted, and I was like, patient, play along. And then they made the patient do another breath test. But that's just an aside for ways that you can't trick TrioSmart. But I was gonna say, I've had this solid subset of patients for whom they've had this flatline test. And then I talked to them, I'm like, how did the test go? Did you have any bowel movements? And they're like, oh my God, McKenna, did I ever immediately start having blowout diarrhea like 10 minutes into the test? And so I think about that as like a flat line that's caused by the rapid transit, where this like bolus of lactulose is transiting the intestine so quickly that it's just kind of like shooting out immediately and doesn't have time to be fermented. And like, that's just, I think, I don't know if that's informed by anything other than the way my own brain works, or if I heard that in one of the millions of SIBO workshops I've been in over the past several years. But I usually end up retesting with glucose or fructose. And so that could kind of account for multiple hypotheses, but that's one that I've included on my list, is just the diarrhea theory.
So picking up on that, and back to what Britta was saying before about enzyme expression, there was a paper published several decades ago, and they highlighted that one of the things that can cause non-gas production, i.e. a false negative, is when the intestine is too acidic. Now, some of these bacteria are actually producing acids. So, for example, E. coli, yes, it can produce hydrogen, but in some circumstances, depending on what you've given it to feed, it will produce acid. And acids denature the enzymes. So the enzymes can't work. And that's not just our enzyme, so the ability to express an enzyme that we can degrade or absorb something, but also the enzymes of the bacteria. And so this paper, I can't remember what year it was, but they did a proof of concept by actually giving people alkalizing salts before running the breath tests. And in a good percentage of them turned negative flatline breath tests into positives, or not necessarily positive in terms of diagnosis, but hydrogen producing. Yeah, go figure. And lactulose can increase the acidity of the colon. So it's another reason for a potential flatline.
Wow.
Pretty infuriating test, right? I mean, like, there's just so many damn challenges with it.
Yeah. But
yeah, and the other issue is with
got diarrhea are more likely to have a more acidic stool, right?
Yeah, and then we have the acetogens as well, which are hydrogen-consuming microbes that make acetate, that only really do that after under low enough pH. which is achievable with lactulose, though, for sure.
Yeah.
So any hydrogen that's produced goes somewhere else that we can't test for.
Yeah, like sugar malabsorption in general causes acidic stool, right? So like fructose or lactose malabsorption causes acidic stool as well, right?
More likely.
I know that's one like stool marker for lactose intolerance that you can like do. It's the curbsiders on chronic diarrhea. It's kind of a good one. They mention NDs in it in like not a terrible way.
Jason, can you send your, if you're willing, your protocol for the 3 gas tests? Because with the handhelds, like they can, my patients can get the sugars over the counter, like on Amazon for like $8. So
Yeah,
I'd love to start doing this triple testing, which is a very interesting idea to me.
yeah, totally can.
Mind sending that? Thanks.
Yeah.
Kind of curious how that plays out.
Can you talk about prep diets for triple testing?
Yeah, I'm more relaxed prep diet than some. I just tend to do a 48-hour low FODMAP diet beforehand. That's it. And actually, you can see some advantage from a methane perspective, not doing a super strict diet as well. You know, because I think sometimes we can miss a, if they've been doing, depending on their transit time and how long they've been doing a strict diet for and how low their general fiber intake is, I think sometimes we could miss a methane issue because they've been on such a low fiber diet for a period of time as well. But yeah, so 48 hours beforehand, low FODMAP.
And continuing into the next few days if they're going to
Yes.
use other substrates.
Yeah, can
That's
just stay on the diet till they're done testing.
Yeah, and it's much easier diet to follow too, because my patients that have done the other diet before are like, oh, thank God, I don't need to do that like white rice and meat diet for a long time beforehand.
I'm curious if we start going like rogue and all do triple testing. I wonder if we can try to collect the data a little bit in an organized way, not like a formal study, but we could quickly put something up on, like we could borrow our survey for hydrogen sulfide SIBO for clinicians and like tweak it a bit. And it would just be really interesting to start seeing treatment. Like I'm just obsessed with like trying to correlate this stuff with treatment response. And so it would just be really, really interesting if like 4 or 5 of us started doing this a lot and then just inputted data. I'd be quite curious. Anyway, just thinking out loud.
Well, wouldn't you have 3 different arms? You'd have the people that just had one test and they got a positive, so they didn't do the other tests.
Oh, I would have them do all 3. I'm thinking that I
You
would
do
have them
everybody.
all 3. Yeah, and then we track our treatment response questions we keep. And then once we get a couple 100 cases, we could, or even less, probably 100 cases, we could run some simple stats on that and be interesting. Like, oh yeah, fructose is a better predictor of treatment response or worse predictor. But fructose is positive all the time, but less of a predictor, or vice versa, right?
Interesting. Yeah, because I do at-home, my patients do at-home testing, that they always did the 3. So they never, like, I can see that if you had your own lab and they showed up positive on the first one, you'd stop there because you've got your diagnosis. But because mine were always doing it at home, we always had the full data on the different sugars.
Cool.
Sounds
Not
like
a
we're gonna
not
have
a
a
hand- Not
I
a
was just gonna-
handheld test though. It's a mail-in test or it's a
Mail
handheld?
in.
I literally was interrupting SSL to just make the joke that we're going to have a Dr. Journal Club probiotic advisor combo study.
Yeah, we should. That'd be fun. We should totally do that. See, I'm surprised we haven't yet, Jason.
True. Good point.
Go.
Any other, this was like one of the best conversations ever. And props to Emer for being like, don't stop it early, Josh. Keep it going. She didn't say it that way. They didn't say it that way. Anyway, so anyone have any other comments or thoughts before we call it a night?
I would just like to briefly discuss scintigraphy, if that's cool. I feel like that was what you were alluding to before, right? So,
Yeah.
I have taken a few dives into the breath test literature in my time here. And I remember it was like Hawaii Doc Talks Goldenberg presentation about breath tests, like
way back years ago, where I found that the highest sensitivity and specificity was associated with this research scintigraphy, you know? And so I'm just kind of wondering like what the status is on that and why that isn't considered more as like a gold standard. And if there's some way that, yeah, I don't know, if that could be utilized more in research as an alternative / better gold standard.
Yeah, let me share real quick because I have those slides up. So Emer, I was like obsessed with this for like Hawaii Doc Talks. I was obsessed, and then I even bought a Heidelberg machine because I was like, I'm gonna just have them swallow the Heidelberg capsules as they take the lactulose, and I'm gonna prove that this is still in the small intestine. Anyway, for whatever reasons, it didn't work out, but so yeah, so you've got studies that I could find on PEG, barium, and scintigraphy. So essentially, what you do is you give them the lactulose, and then with PEG, it's so clever. You also give them a bunch of PEG, and then they have a tube that goes all the way down to the cecum, and they just start pulling sample, and they pull until they start seeing PEG in the tube, and that's when they know that the bolus has made its way to the cecum, and then they try to correlate hydrogen rise from the lactulose before that, essentially. And then with barium, it's a kind of similar idea. You give them barium, but then you're imaging to see right before it gets to the cecum, and make that, and then try to correlate your hydrogen levels with right before that cutoff. And then with scintigraphy, it's the same idea. You're basically trying to measure, so if that's your cecum, you're trying to measure when the radioactive material gets there and then correlate the hydrogen levels from before that. Did I answer your question or not at all?
Yeah, I guess then like, why don't you like it? Like what happened to your Heidelberg machine? Like where did it go?
It's in pieces in the closet. But so like PEG, like you need to aspirate all the way down the cecum. So that's like not practical. Scintigraphy is, radioactive. And you have nuclear medicine, and then barium, you'd have to do like serial imaging for a couple hours, and so that's a challenge, and you'd have to be sampling them while they're in the hospital. So it's just not pragmatic. The thought with the Heidelberg would be that it would be a little bit more pragmatic, and I still believe that it would be. But then I brought this up to Pimentel, and he thinks I'm an idiot because his argument is these capsules do not move at the same speed as everything. So that's the other problem, is that liquids, foods, and everything moves at different speeds. Yeah. And so according to him, and he's probably right. So I was always like, why don't you do a smart pill? Why don't you do Heidelberg capsule with the lactulose? And his argument was, even if it said something, I wouldn't believe it because that capsule is going to move at a different rate than the lactulose or something along those lines.
And I'm not sure why you're talking about a Heidelberg. What's that going to tell you about lactulose?
So my crazy idea was, you know how it's attached to a string, the little capsule thing? Cut the string, just swallow the damn thing, and you have the receiver. And using the pH level, you can infer when it goes from the small intestine to the large intestine, which is how smart pills work anyway, plus the pressure. And I ran this by the Heidelberg people, and they're like, yeah, there's no reason that wouldn't work. And some crazy docs are having them swallow it for days. And I was like, cool, I'm going to be one of those crazy docs. And then, just like nothing. I think COVID happened. And then I was just like, I'm not doing this again.
Okay, so you'd just be measuring when the capsule leaves the stomach.
No, I'd measure it when it leaves the small intestine.
Oh, because you expect to go from alkaline back to acid again when it gets to the colon?
Yeah, so I don't, you would know better than I, but my understanding from the smart pill is that the way they're able to figure out where it is by pH changes plus the pressure for valves. And so that was my assumption, is that I would look for pH, a quick phase shift, and that would be when it goes into large intestine, in theory.
How long would you have to do that Heidelberg test to wait for the results? I mean, we already take 2.5 hours doing it sometimes just in the stomach. But it's tethered in those cases. How fast do you think that would move through?
Right. Well, I mean, if you're taking lactulose and it's still not leaving the stomach in 2 hours, you've got other problems.
Yeah, but you're talking about following it all the way down to the colon.
Mhm.
How long is that going to take?
Well, in theory, it would, but the thought was that it would go with the lactulose. It would go with the bolus.
Oh,
That was my theory, and Pimentel thought I was an idiot, and he didn't use those words, but I read between the lines. And I think it's because you can release that liquid and still hold on to a solid, and then it'll move at different rates and all
yeah.
that.
I think it's not a really good measurement necessarily.
I'm reading between the lines, and I think you're also calling me an idiot. Well, I'm glad I didn't do it then. Cool. Any other last minute thoughts?
Going back to the scintigraphy, it does seem like impractical for clinical practice, but is it that much more impractical than a, endoscopy with aspirate? Like it's a bit less invasive in terms of the need for like anesthesia and things like that.
Nobody
So-
does aspirates. Nobody. So I was
Right.
calling
It's
around.
only in research.
It was in the research in the 90s in Scandinavia. Like I found a lab that did it, and they had to pull a manual off the shelf, dust it off, and they found a reference from like the Scandinavian Journal of Gastroenterology, like 1998. They sent me the paper, and they're like, I think this is what we would follow. We've never done it. And when I reached out to GI docs out here, and maybe Colorado Springs is different than Portland, but they were like, what protocol do you want us to follow? So I don't know. I don't think anybody does that as a regular rule outside of research as far as.
Although Rao is doing it for fungus, right?
Yeah, so he did it. You did the famous fungus study with that. But yeah, that was very specific research study, I think. Is he doing that clinically?
I think he does it clinically. I had one patient
Really?
who went to see
Yeah,
Rao, and
I
they
think
did
so.
Oh, wow.
sample the small bowel. Yeah.
Oh, cool. And is he using the new cedar-cyanide device, or he's just using a regular?
That I couldn't answer. It was only with one person
pretty
that did a while ago.
I'm pretty sure I saw a paper authored by him in which he like presented his own technique for sterile aspiration of small bowel. I could be just confusing it with cedar cyanide, but I think Rao, like maybe it's the same device, maybe it's different, but he has his whole own thing as
Okay.
well. And Josh, I'm really into the commitment of like Scandinavian gastroenterologists and like a Heidelberg machine in your closet. And also, I still have the same question that is, like in research. So yeah, no application to clinical practice, right? But in terms of just like a full-on Dr. Journal Club mindset, why could we not use some form of scintigraphy as an alternate gold standard? If we know that our gold standard sucks, do we know that these other scintigraphic options for trying to suss out the transit of the small bowel suck as bad,
Gotcha. Well, it'll tell you the transit time up to the cecum, but it won't tell you if they have SIBO or not. So you're saying use it, like only call it SIBO if there's a rise before the scintigraphy gets to a certain point?
I guess I'm talking about replicating the studies that have used scintigraphy, like I think what you were just talking about, right? Like lactulose mixed with barium
Mhm.
and then tracked serially with imaging, right? Like I would have to go back into the papers to look at what they did. But like, this is what I was saying when I first said the question, is that I remember looking deep dive and being like, why is the sensitivity and specificity so different in these trials, in these like systemic reviews and meta-analyses, and going back into the papers with the trials with the highest sensitivity and specificity and finding that they were using these scintigraphic techniques to get that sensitivity and specificity. Like the ones that were like 85s and 90s were like using special transit mapping techniques.
Oh, interesting. And then, but how are they making a call on SIBO? How are they making the SIBO diagnosis?
With a combo like bolus thing.
Aspirate
And so, like they were like, yeah.
Oh, interesting. Oh, cool.
Yeah.
So you did bigger.
I think I'm gonna have to go back in because this is like, once again, this is Hawaii Doc Talks era SIBO breath test presentation. So these are like older studies.
Yeah. Oh, cool. Yeah, I thought those studies were brilliant, and it also scared the hell out of me because, they report the average, 90 minutes, 80 minutes, but that's just the average, right? So like the range is absurd. It's something like one study was like the lower end of the range was like 18 minutes to hit the cecum. Like 18 minutes, right? Like that's crazy. How do you trust a breath test if some people are coming in 18 minutes?
Which would make it a great gold standard.
18 minutes.
Yeah, that would be a pretty strict cutoff. That's true. Yeah. All righty.
Okay, I have one last thing because I asked Josh if we could go to 7:30. If anybody's taking requests, can we do a journal club of the European guidelines?
Oh, good idea. That's a good idea. Okay, did you just
Incorporate some
volunteer
of it
yourself?
into next week.
Did you volunteer yourself for next month?
Can I volunteer Sharon or Jason?
Sharon, you've been voluntold.
Yeah.
Sweet. All right, Sharon's next month. Awesome.
Yeah, I'm happy to do next month if you want me to. I can incorporate aspects of the European guideline. They're a little different. I mean, I think probably what would be quite good would be for somebody to do a deeper dive into comparing the European and the North American guidelines.
Yeah, that would be cool.
Because there are, I'll see if I've got capacity to do that, particularly in some of the things that have come up today. Yeah, so for one of them, then that was kind of a parting question from me is, you know, we've still got this huge variety of increases in parts per million. You know, are we using +10 sustained for 2? Are we using +20? Are we using +12 of methane? Are we using +15 combined? You know, all of those different criteria that are around and about out there, they make interpreting the tests a little bit of a nightmare. I mean, you can make it swing any which way you want, right?
Well, Sharon, you got to go ACG. And then all those problems go away. No, totally. No, agreed. I don't know. It's so funny how we just kind of put that to rest ever since the ACG came out and everyone just points to it and as if all these other debates didn't happen.
Yeah.
Well, cool. That would be excellent. I think that'd be really, really interesting. I don't know the European guidelines well. I think Sharon, you sent it to me a while ago. I think I briefly looked at them, but I would love to have a deep dive on that. And so you were saying you found that clinically relevant to use that over or in addition to North American / ACG?
Yeah, I use it to guide, for example, the dose of glucose. So North American is still saying 75 grams, unless the person's under a certain weight, but the European guidelines is to blanket 50, which makes a lot more sense. And a couple of other things as well, but it's not hugely different. There are just some fine differences. Yeah. And like I say, it's a bigger consortia.
Me and Emer are gonna volunteer to present it together. We're gonna do it together next time. I was gonna volunteer not to open another can of worms, but to do the Nordic study that just came out on Sunday to anyone who hasn't read it yet. But there is actually a really great journal club esque type presentation by he's very biased in that he's written some of the literature on similar studies, but he did one, so I'll post it in the group. But on that was just hot off the press on Sunday.
What's the study?
What Nordic study? Is this the colonoscopy study?
Yeah, this is the colonoscopy study that just came out on Sunday.
Yeah, we got to do that one. Everyone's been obsessed about it. Clearly, yeah.
Right. So next month is Sharon with fructose, then me and Brita with the comparison head-to-head Euro versus America.
Yes.
I just want everyone to know that I'm first generation Irish. Okay, so I'm Team Europe. And then the third month is Josh doing the Nordic study.
I'm going to defer that. Actually, Adam wants to do that one. So I get away. I get a 3 month, a bi-month, 3 bi-month, if that's a thing. But yeah. Cool. Okay, that keeps us busy for a while. So
yeah, solid.
All righty. Okay, thanks so much.
Thanks so much.
Thanks, everyone.
Nice seeing you all.
Good to see you, Australia. Fun to have you. Thanks for.
Yeah, I teach a class from like 11 till like the middle of this one, so it's actually really hard for me to meet this one, bar the last bit, but I'll do my best to get here when I can.
Thank you.
All right, take care, everybody.
Bye.
Night.